بسم الله الرحمن الرحيم.
قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is the second part of our lecture, Regenerative or Reconstructive Osseous Surgery, presented by Professor Mona Yehia Abdelrazak. Because of the previously mentioned negative factors that could be associated with the use of non-resorbable barriers, these have stimulated research for the development of bioabsorbable devices mainly made of collagen, polygalactic acid, polylactic acid, and or copolymers of these materials that could eliminate the second surgical procedures, thus saving the patient and the newly regenerated tissues from additional surgical trauma associated with membrane removal. The types of bioabsorbable barriers include first generation collagen, oxidized cellulose, cargile membrane, hydrolyzable polyester, polylactic acid, vicryl mesh, or polygalactin 910. The second generation is composed of synthetic liquid and polymer, which is known by the Atrisorb. Collagen is a natural and an integral part of mammalian tissues. There is a similarity between collagen in human skin and certain tissues. Since human body enzymes can degrade animal collagen, collagen is attractive as a barrier material. Furthermore, collagen has the following advantages. Collagen is chemotactic to fibroblasts. It enhances fibroblast attachment via its fibrillar scaffold structure. It stimulates platelet degranulation, thereby accelerating fibrin and clot attachment. Being semi-occlusive, it allows for essential nutrients to pass through the membrane. This may reduce unwanted sequelae such as flap necrosis. Collagen is incorporated into the surrounding tissue with an average retention time of 6 to 7 weeks and total absorption at 8 weeks. Bioresorption of collagen occurs naturally through catabolic processes resembling those in normal tissue turnover, that is to say, degradation by normal collagenolatic enzymes and phagocytosis. Degradation of collagen occurs without local inflammatory response. Collagen has been also demonstrated to be a weak immunogen. One of the bioabsorbable type 1 collagen membranes, marked as BioMend, is derived from bovine Achilles tendon. Bovine tendon is known to be one of the purest sources of type 1 collagen that can be readily obtained and processed in commercial amounts. BioMend has an effective pore size of 0.004 microns, which will effectively retard epithelial downgrowth during early phases of healing. This is a preoperative view and preoperative. We raise a mucoperiosteal flap for the treatment of the defect using falcular incisions. Care should be taken to preserve the attached keratinized gingiva and interdental papillae, as this will facilitate subsequent membrane coverage. Vertical incisions may be utilized to gain greater access to the defect area and assist in membrane coverage. The vertical incisions should be placed at least one tooth mesially and or distally to the tooth being treated. The BioMend membrane should not be placed beneath these vertical incisions, as delayed healing of the flaps may result. Pocket epithelium is excised, leaving a connective tissue layer for the membrane to interface. At this time, an appropriately sized BioMend sheet is chosen and hydrated for approximately 5 to 10 minutes prior to final placement. The membrane may be hydrated in its inner blister packaging by introducing sterile water or saline. Hydration will increase the pliability and adaptability of the membrane. Alternatively, the membrane will become pliable upon contact with blood and fluid in the defect site. Once the defect has been prepared, the BioMend membrane must be trimmed to properly fit the defect site. A sterile template made from medical grade high-density polyethylene is separately packaged and included with each BioMend membrane to assist in trimming the membrane to final configuration. Three popular free-form patterns are provided as a guide and may be conveniently punched out of the template. The template material is also embossed with a raised pattern to further distinguish it from the membrane. This is a class 2 furcation prior to membrane placement. The template material is trimmed until the proper configuration is achieved. It is then placed against the collagen membrane and a duplicate shape is trimmed from the membrane. Smooth, rounded corners, as we see, should be trimmed from the collagen membrane to avoid possible perforation of the overlying tissues. The template material is not implantable and should be discarded immediately following modification of the membrane. Note that the membrane will be required to extend beyond the defect margins by a minimum of 3 mm mesially, distally, and apically. The coronal portion of the membrane must lie above the alveolar crest, apical to the gingival margin. Guided tissue regeneration is also indicated in distal defects. A horseshoe type or U-shaped configuration is well suited for this type of defect. Since no tooth adjoins the defect, the membrane may be sutured into place using an absorbable suture with a non-cutting needle via the sling suture technique. The membrane is inspected for good adaptation to the tooth root and a lack of folds. Flaps are coronally positioned to ensure complete coverage of the membrane. Incisions are closed with the suture of choice. GTR is also indicated for the interproximal defect. This is an interproximal defect prior to membrane placement. This type of defect can be treated by trimming an H-type configuration. The wound is thoroughly debrided and the BioMend membrane is trimmed with the aid of the template material, as we said before. If the membrane is sutured into place, two options may be considered. The sling suture technique using absorbable suture material with a non-cutting needle. Alternatively, the membrane can be sling sutured around both teeth engaged by the H-type configuration. This prevents collapse of the membrane into the defect area. The membrane is inspected for folds and the buccal flaps are coronally positioned over the material. This diagram represents the results of a study comparing the BioMend with the Gore-Tex periodontal material. As we see, the BioMend in violet and the Gore-Tex periodontal material in blue. There is a decrease in the probing depth, decrease in gingival recession, gain in probing attachment, and a horizontal defect fill in the favor of the BioMend membrane. The Atrisorb barrier membrane, which is produced by Atrix Laboratories in Fort Collins, is formed of polymer of lactic acid, poly-DL-lactide, which is dissolved in N-methyl-2-pyrrolidine. The Atrisorb GTR barrier was specifically created to meet the 5 design requirements for regenerative membranes: tissue integration, cell separation, space maintenance, biocompatibility, and clinical manageability. Functioning as a barrier device that isolates the wound site from epithelial tissues and gingival connective tissue, it gives slower growing bone and periodontal ligament cells an opportunity to regenerate. The Atrisorb GTR barrier is quickly applied as a flexible, semi-solid film, and once in place, adapts to form-fit the surgical site. The barrier transforms into a biodegradable solid implant when exposed to the aqueous environment of the mouth. As we see here in number 1, this is a periodontal defect which is treated by the application of Atrisorb barrier in number 2. Number 3 show the defect isolation, then the bioabsorption of the membrane in number 4, and final periodontal regeneration in number 5. The Atrisorb barrier membranes come in the forms of liquid and polymer, accompanied with a case lined with a porous pad and spacers. The first step, we expel the contents of the formulation into the porous pad to form a pool between the spacers, as we see here. Then we close the case by pressing down on the vertical tab. The case should be closed with an audible click. Do not press on the flat surface of the case. When the timer sounds, immediately we open the case. While the barrier is forming, clinical measurements can be taken to include sufficient length and width to allow adequate coverage of the defect and the adjacent bone, usually 2 to 3 millimeters. Careful measurements before cutting the barrier will eliminate the need for additional trimming of the barrier once placed at the surgical site. However, if necessary, the barrier can easily be removed, trimmed with surgical scissors, and replaced at the surgical site. Use the microspatula to gently detach the formed barrier from the porous pad and transfer the barrier to the cutting grid. Using 1 mm grid pattern as a guide, we cut the barrier to the desired dimensions with the blade. As we see here, it is possible to cut more than one barrier from the initial formed barrier depending on the site of the defect being treated. We use the cotton pliers to position the customized barrier on the defect, as we see in figure 9. In figure 10, we adapt the barrier up to the defect using a cotton tip applicator moistened in a sterile sodium chloride solution. Note, when placing the barrier interproximally, it is best to first pass the lingual extension through the interproximal space from buccal to lingual, as we see in figure 11. Then We rotate the barrier into position and again adapt the edges with a emulsive cotton tip applicator. The barriers are not sutured into place. They have modest adhesion properties and will adhere to the tooth and surrounding bone. Minimal care is required to prevent them from dislodging during suturing the flap. Suture the flaps in a manner to completely cover the barrier membrane, as we see in figure 12. This is a lingual view of mandible first molar before treatment with Atrisorb. Figure 2 represents the lingual view of the mandibular first molar after flap elevation and debridement. Note the class. This is a lingual view after application of the Atrisorb GTR barrier over the furcation defect. And figure 4 represents the lingual view at the time of surgical closure. The gingiva margin has been replaced at its original location. Note that the barrier is exposure particularly over the distal root. One week after surgery, the lingual view shows that the barrier is present and its coronal border is apparent. And in figure 6, this is 1 month post-surgery. The barrier is present and intact. Its coronal border remains exposed. Figure 7 represents the lingual view at 6 weeks post-surgery. We note that the remaining small remnants of the barrier is still present. This is the last time point where the barrier was visible. In figure 8, this is a lingual view after 12 months post-surgery. The periodontal pocket depth had decreased by 4 mm from baseline 5 mm and 1 mm after 12 months. And there had been a 4 mm gain in vertical attachment. It was 7 mm at baseline, then 3 mm after 12 months. The horizontal furcation depth had decreased by 4 mm. It was 4 mm at baseline and 0 mm after 12 months. In case of membrane exposure, the following should be done. First of all, we have to monitor plaque control frequently until the material is removed. We should instruct the patient to rinse with chlorhexidine. Do not attempt to cover the material that has been exposed. If complications develop, consider. In transgingival configurations, the membranes are typically removed between 4 and 12 weeks. However, for the submerged configurations, the membranes are typically removed between 4 and 9 months. Preliminary results indicate that longer time frames may be associated with improved results. This allows for protected maturation of the newly regenerated tissue. The surgical procedures for guided tissue regeneration. Number 1, for the intrabony defect. A circular incision should be performed to allow full thickness mucoperiosteal flap reflection. Care should be taken to preserve the attached gingiva and interdental papilla, as this facilitates subsequent coverage. Number 2, vertical releasing incisions may be used to gain greater access to the defect area and assist in membrane coverage. The vertical incisions should be placed at least one tooth mesially and or distally to the tooth being treated. The membrane should not be placed underneath the vertical incisions, as delayed healing of the flap may result. Number 3, the pocket epithelium is excised, leaving a connective tissue layer for the membrane to interface. Number 4, we remove all granulation tissues from the surgical site and undersurface of the flap. The defect is thoroughly debrided with hand instruments, ultrasonic scalers, diamond finishing burrs, or any combination to ensure complete removal of granulation tissue, calculus, and plaque. Number 5, the root should be carefully inspected for anatomic defects that would interfere with optimal healing, including cervical enamel projections and bifurcation ridges. When noted, these structures should be removed with either low or high speed rotatory instruments. Following instrumentation, an adequate blood clot should form in the treated defects. The use of root conditioning, bone grafts, or synthetic bone substitute as an adjunct to guide tissue regeneration is at the discretion of the clinician. Salivary contamination of the wound site should be minimized. Then the membrane is prepared according to the manufacturer's instructions and trimmed to properly fit the defect site and to remove sharp corners and irregularities. The trimmed membrane is then positioned against the root surface coronal to the alveolar crest. The collar of the material should be at or slightly below the cement-to-enamel junction. The membrane should extend at least 3 mm beyond the margins of the defect and should extend 2 to 3 mm over the lateral borders of the entire defect. When suturing the membrane, it is advisable to suture it to the proximal tooth to achieve additional membrane stability. In these cases, the membrane should be engaged 2 mm from its lateral edge using a non-cutting ground shank suture needle. Absorbable suture material is used in case of bioabsorbable membranes, or Gore-Tex suture material for non-resorbable membranes, and a sling suture design. The flap can then be positioned coronally and sutured to obtain primary closure. It is advisable to suture the interproximal papilla closest to the membrane, the material first, followed by suturing the rest of the surgical field. Coronal flap positioning can be facilitated by either vertical releasing incision extending beyond the mucogingival junction in the buccal side, that should be 1 tooth mesial and distal to the GTR side, or horizontal releasing incision can be made through the periosteum. Be sure to consider the related surgical anatomy to further relax the flap. In the lingual side, vertical and horizontal releasing incisions are not recommended. When necessary, surgical flap can generally be extended by grasping them firmly and gently pulling them in coronal direction. This is a 30-year-old male patient presented with localized advanced periodontitis associated with the lower molar. Clinical examination revealed a circumferential defect involving the distal and distal-facial aspect of the tooth, slightly involving the buccal falca. This is the pre-operative view. A full-thickness mucoperiosteal flap is raised to view the circumferential defect. Defects are debrided and measurement made from a reference stent. The collagen membrane is customized and placed over the defect without suturing. Note that the membrane is placed just below the cement-to-enamel junction and covering the 2 to 3 mm of the surrounding bone. Post-operative view at 1 week exhibits excellent tissue response and healing, as we see. Surgical re-entry at 9 months demonstrates new bone formation. This is the pre-surgical radiograph and the post-surgical pre-epical radiograph after 9 months, illustrating. This is a 47-year-old female patient presented with a localized periodontal defect associated with tooth number 5. Periodontal probing pocket depths were 10 mm on the mesiobuccal with bleeding upon probing. Tooth number 5 did not exhibit mobility or gingival recession. Following adequate local anesthesia, internal bevel incisions were made buccally and lingually with intention. Circular incision with full thickness mucoperiosteal flap was raised to view the circumferential defects. Calculus was noted on the root surface. The ultrasonic scaler was used to debride. Also, a low-speed diamond burr was used to plane and smooth the root surface. The collagen membrane is trimmed and placed over the defect without suture. Flap positioned coronally and primary coverage. Healing at 6 months post-operatively shows substantial reduction of pocket depth, 8 mm, and minimal risk. Surgical re-entry at 6 months demonstrates new bone. This is the pre-surgical periapical radiographs and the post-surgical periapical radiographs at 6 months illustrated. The surgical procedures for guided tissue regeneration in case of recession defects is as follows. First of all, an intracellular incision is extended horizontally on both sides of the recession, perpendicular to the root axis. The interdental papillae are disepithelialized slightly higher than the gingival recession in coronal direction. Then 2 vertical incisions perpendicular to the alveolar bone crest are performed on both sides of the recession. These incisions are parallel and as high as it is necessary for tissue displacement. A full thickness flap is raised, thus the cortical bone is exposed 3 to 4 mm beyond the recession. Then the incisions are then superficial and slightly divergent, corresponding to a partial thickness portion of the flap. During this dissection of the alveolar mucosa, the lancet gradually moves away from the bone surface. Modifications are possible in the design of the incisions. A single mesial vertical releasing incision or an intracellular incision horizontally extended to the adjacent teeth may be adequate to coronally position the flap. The root surface is then inspected at this time of the procedure and its preparation may be completed. The few millimeters bordering the recessions are checked. The appropriate configuration of the membrane is selected, trimmed, positioned, and sutured with a sling suture and palatal or lingual knot. On the opposite side of the tooth, on the palatal or lingual aspect, an intracellular incision is performed and a small mucoperiosteal flap is raised in order to completely submerge the ligature. The buccal flap is readapted to the tooth to cover the matrix barrier as completely as possible. A sling suture around the neck of the tooth adapts the flap to the desired coronal position. The flap is sutured laterally and an apical periosteal sutures complete the perfect stabilization of the tissues. This technique is adapted to multiple recessions or 2 or 3 contiguous recessions. This is a diagram representing a single-step, single-site surgery with the bioresorbable GUIDOR Matrix Barrier. On the left we see the incision of full thickness flap and periosteal dissection, a circular incision and 2 vertical incisions. On the center, the membrane is placed and secured over the defect and extending to the bone. Note that at the apical part, the flap is partial thickness and not full thickness. Then the flap is coronally positioned and sutured over the membrane. This study was done to compare the treatment of gingival recession by using guided tissue regeneration as a single step compared with connective tissue graft as a double-step surgery. The site is treated with titanium reinforced membrane, is shown in the left. This is a preoperative gingival recession. In the center, the titanium reinforced membrane is bent and secured by sling sutures. Then the coronally positioned flap covers the membrane and is secured by sling crown attached. And this is the results of the treatment of gingival recession by guided tissue regeneration after 12 months post-surgery. Here the control site is treated by connective tissue graft. As we see in the left, this is the pre-operative gingival recession. In the center, the connective tissue graft is harvested from the palate, and then the graft is sutured at the recipient site. And this is the result of the treatment of gingival recession by connective tissue graft or double-step surgery after 12 months post-surgery. As we see, the results of both types of treatment are comparable, almost the same. The post-operative protocol for guided tissue regeneration is: if a periodontal dressing is used, it should be applied gently and in soft consistency to avoid collapse of the material into the defects or apical displacement of the flap. A broad-spectrum antibiotic, doxycycline hyclate, 100 mg per day for 10 days, or tetracycline, 250 mg 4 times daily for 14 days, may be prescribed prophylactically to reduce the risk of infection. Sutures are removed the 3rd or 4th. The patient should not clean the treated area by brushing, flossing, or other interdental cleaning techniques for 3 to 8 weeks. During this period, the patient is instructed to rinse with 0.12% chlorhexidine solution. Following dressing removal, chlorhexidine should be applied to the surgical site with a cotton tissue. After this period, mechanical tooth cleaning can resume. Continue twice daily application of the anti-infective agent for an additional 4 to 8 weeks. After the initial 8 weeks period, maintenance recall visits should be scheduled to monitor patient plaque control. Weekly for the first month, bi-weekly second month, and 3 months thereafter. Professional supragingival plaque removal should be performed every week for 4 weeks. Prophy caps without pumice powder, then bi-weekly for 8 weeks. Probing and subgingival scaling should not be performed prior to 6 months following surgery to prevent damage to the immature regenerated tissues. Radiographs should be taken after 6 months, preferably 1 year, to truly assess the potential complications from guided tissue regeneration failure could be gingival recession, flap sloughing, resorption or ankylosis of the treated roots, thermal sensitivity, some loss of crestal bone height, abscess formation, infection, pain, gingival irregularities, complication with the use of anesthesia. The lecture is to be continued.